Chapter 17, The Mechanics of Breathing. This is another chapter that's actually really easy to understand. We're going to go over the concepts and look at some of the pictures so that we understand what's happening whenever we're breathing in and breathing out. The muscles that we use, what happens with the pressure inside the thoracic cavity, and the volume inside of the lungs. You'll definitely have to know these functions of the respiratory system. First and foremost, this is easy. It's the exchange of gases between the atmosphere and the blood. What are we doing? We're bringing in oxygen, and then we're going to breathe out carbon dioxide. The reason why oxygen is so important is because it is used in aerobic respiration. It goes to the cells, goes into the cell, and it goes to the mitochondria. Mitochondria takes the oxygen, breaks down the glucose to make the most ATP possible. All right, so one of the byproducts of aerobic respiration is carbon dioxide. So that's why we breathe in oxygen and we breathe out carbon dioxide. Not all of the carbon dioxide actually is going to be exhaled. Some of it is used to make carbonic acid, and it is used in your regulation of your pH, which is the next function. The respiratory system is also used in regulating the body pH. Well, how does it do that? Well, it does that with carbon dioxide. Whenever carbon dioxide is in the blood, the more carbon dioxide there is in the blood, then the more acidic you are. So if you breathe off more carbon dioxide, then it'll raise your pH to make you a little more alkaline. Or if you breathe off less carbon dioxide, which means you keep more of it in your system, then it will lower your pH, make you more acidic. All right, another function of the respiratory system is to protect yourself from inhaled pathogens and other things that you might be breathing in. I wish the air that we're breathing in could be pure, but it is really not. So we're breathing in all kinds of dust mite and dirt and all kinds of pollutants. So there are mechanisms in place for the lung to take care of that. One of it's called the mucociliary escalator, where the trapped particles particles will be trapped in mucus layer it lines most of the airways, and then it is propelled up from the cilia, so you can either spit it out or swallow it. And then there are some macrophages located in the alveoli to help get rid of inhaled pathogens. And then we also use the respiratory system for your vocal cords. So as air moves through the larynx, if the vocal cords are closed, they vibrate and they create the sound known as your voice. The principle behind the flow of air, what dictates where these molecules are going, there has to be a pressure gradient. This is the same thing we've been talking about in the cardiovascular system. The fluids and airs follow the same principle. They go from regions of high pressure to low pressure, so there has to be some sort of pressure gradient. Well, if there has to be a pressure gradient, that means there has to be some sort of mechanism in place to create a pressure gradient, and that's what the muscular pump is. The muscular pump in the cardiovascular system was the heart. The heart created high pressure to push the blood into the circulatory system, and then the pressure gradient will make the blood flow to the system. So again, the same thing is happening with the respiratory system, but the muscular pump in this case are going to be the muscles of the thoracic cavity, like the diaphragm and the floor of the thoracic cavity, and the intercostal muscles. There are external intercostal muscles, internal intercostal muscles, plus there's even some spinal muscles that can help, and also some abdominal muscles that will help with respiration if we need to breathe in as much air as possible or breathe out as much air as possible. The other principle to airflow is resistance, and again this goes along with fluids. We talked about resistance in the cardiovascular system with the chapter on the heart, and also the chapter on the flow of blood through the system. Resistance opposes flow. So the higher the resistance, the lower the flow. And the same thing happens with air. But when resistance in the airways has to do at the bronchial level, where we have smooth muscle that surrounds the bronchioles, they will constrict or dilate the bronchioles. It's called bronchial constriction or bronchial dilation. If the bronchioles are dilated, that means they are opened and there's more air that can travel through, so airflow goes up. If the bronchioles are constricted, that's bronchoconstriction, that increases resistance, which will then lower the airflow. There are 4 processes in place when it comes to respiration. These are the 4 processes right here. First, we have ventilation. Ventilation is simply breathing in and breathing out. There's pulmonary ventilation, and then there's also alveolar ventilation. Pulmonary ventilation is breathing air into and out of the airways. Alveolar alveolar ventilation is moving air into and out of the alveoli. So ventilation is breathing in, which is known as inspiration or inhalation or inhale, and then expiration, which is breathing out or exhalation. So that happens first in the respiratory system. And then there's an exchange. Whenever there's an exchange of gas, it's going to be through a membrane. So we have an exchange of oxygen and carbon dioxide between the lungs and the blood. We're talking about the alveoli of the lungs and then the pulmonary capillaries of the blood system. Oxygen crosses through the respiratory membrane, the pulmonary membrane into the pulmonary capillaries, and then carbon dioxide is leaving the pulmonary capillaries. They cross the pulmonary respiratory membrane and go into the alveoli. And then we have transport of oxygen and carbon dioxide, which is done by the red blood cells, the erythrocytes. They are transporting the gases. Oxygen and carbon dioxide will both bind to the hemoglobin. Carbon dioxide will also happen to dissolve in the plasma. It can be carried by the water of the plasma as well. And then we have an exchange again between exchange of the gases between blood and the tissues, the cells, and that happens through the capillary endothelium. We have oxygen leaving the systemic capillaries, going to the tissues, and carbon dioxide leaving the tissues and going into the systemic capillaries. And that's what this picture is showing here. We have oxygen, it's going into the alveolus, and then it's going to cross through the pulmonary membrane into the pulmonary capillaries, into the pulmonary veins. Now, what dictates the movement of oxygen into the capillaries? That has to do with the concentration gradient. The concentration of oxygen as it's coming through the pulmonary capillaries to the pulmonary artery is low. So then oxygen will cross through the membrane, go into the pulmonary capillaries, going down its concentration gradient. And now the oxygen is carried to the left side of the heart. It goes through the left atrium, through the bicuspid, into the left ventricle, then through the aortic semilunar valve into the aorta, which is the systemic circulation. And then it travels through the systemic arteries till we get the systemic capillaries. And now oxygen will then exit the systemic capillaries, go into the tissues, because it's again going down its concentration gradient. The concentration of oxygen is going to be low inside of the cells because it's being used by the mitochondria to make ATP. Well, one of the byproducts of aerobic respiration is carbon dioxide. So now the oxygen is going into the cells. Carbon dioxide will go down its concentration gradient into the systemic capillaries. So now the carbon dioxide is going to go through the systemic capillaries, systemic vanules. The carbon dioxide then goes through the right atrium, through the tricuspid valve, through the right ventricle, through the pulmonary semilunar valve, and then into the pulmonary capillaries, pulmonary arteries, and then carbon dioxide will exit the pulmonary circulation through the pulmonary respiratory membrane into the alveolus, and then it'll then continue out and then be breathed out through exhalation. Let's review a little bit of the anatomy of the respiratory system. We have an upper respiratory system, and then there's a lower respiratory system. Upper respiratory system starts in the head, goes all the way down through the trachea. Once the airways enter into the lungs, that's part of the lower respiratory system. So if we start at the top and work our way down. Air travels in through the nasal cavity. Air can also travel in through the oral cavity, but we're going to stick with the nasal cavity. It should be easier and better to breathe through the nasal cavity because once air goes into the nasal cavity, it is lined with the mucosal membrane. The air can be warmed to body temperature. It can also be humidified because humidified air is easier to breathe in and get to the alveoli than dry air. All right, once the air enters through the nasal cavity, it then goes through the pharynx. We have the nasopharynx, then we have the oropharynx, and the laryngopharynx. And then air goes past the epiglottis, through the larynx, and then into the trachea. The trachea is also known as the windpipe. The trachea then transports the air, it goes down, and then it has a choice to go into either the right or the left lung. So it splits right here at the carina. The carina is that part of the trachea where it splits into a primary bronchus. There's a primary bronchus that goes into the right lung, so this will be the right primary bronchus. Then there's a left primary bronchus that goes into the left lung. Once air gets into the primary bronchus, then we get to airways that are smaller and smaller. It branches off into bronchioles, and then the alveolar duct, and then to the alveolus. If you remember the two lungs, there's a right lung and a left lung. The right lung has 3 lobes to it, a superior lobe, a middle lobe, and then an inferior lobe. And then the left lung has only 2 lobes, the superior lobe and then the inferior lobe. The right lung is actually going to be shorter and kind of squatter than the left lobe, which is going to be a little bit longer and skinnier. And that has to do with the liver. The liver is on the upper right quadrant of the abdomen, and it kind of pushes up a little bit, and that's why the right lung is a little shorter than the left lung. There are tissues that surround the lungs, and it's called the pleural sac, and it's made of pleural parietal membranes and pleural visceral membranes. On the surface of the lung itself is the pleural visceral membrane, and then on the surface of the thoracic cavity is the parietal pleural membrane. And then there's a potential space between the two membranes called the pleural cavity. Now this space is not an air-filled space, it is filled with a liquid known as pleural fluid. And it is a lubricant that allows for your lungs to be able to expand, and when it fills with air, and they contract as we exhale, and then the two surfaces will glide across each other instead of causing friction and heat. Also, there is a tension, a water tension between the two surfaces, and it helps keep them to stick together. It helps keep the lungs inflated as we breathe in and breathe out. Whenever air does get into the thoracic cavity, it's called a pneumothorax, and then it causes the two membranes to lose contact with each other, and then the lung will deflate. And they'll have to, in order to inflate that lung, they'll have to get the air out of the thorax, and then it allows the lung to re-inflate. If we look at the left side of this picture, it shows you the different muscles of the thoracic cavity, and the main muscle for breathing in is going to be the diaphragm muscle, which is located in the very bottom of the lungs right here. It separates the thoracic cavity from the abdominal cavity. And then we have intercostal muscles. The internal intercostal muscles, the way they are arranged, whenever they contract, they squeeze down and they bring the ribs closer together so you can breathe out as much air as possible. And then the external intercostals, the way they are arranged, whenever they contract, they pull the ribs slightly apart so that you can breathe in as much air as possible. Then we also have the sternocleidomastoid, which can lift up and elevate the sternum and also elevate the clavicle so that you can increase the volume of the thoracic cavity to bring more air in. Then we have the scalene muscles, which are between the clavicle and the first couple of ribs, and they also will help spread apart the rib cage to help you breathe more air in. And then we have the abdominal muscles right here, and whenever they contract, then they can decrease the volume inside of the thoracic cavity, can force more air out. This picture on the left shows you the airways, starting with the larynx. Then we have the trachea, and then we have a primary bronchus, which leads to a secondary bronchus, which then leads to a tertiary bronchus, and the airways keep getting smaller and smaller. So the airways will diverge and get smaller, just like systemic arteries or pulmonary arteries. And then the tertiary bronchus will lead to a bronchiole, and then the bronchiole leads to an alveolar duct, which leads to the alveoli. The alveoli being the smallest part of the respiratory tree where we have the actual gas exchange. All right, in this picture on the right-hand side, it shows the pulmonary circulation. We have pulmonary capillaries, pulmonary arteries, and pulmonary veins. You'll remember that the pulmonary arteries are blue because they're carrying oxygen-poor blood. It's carrying this blood from the heart to the lungs, which is why it's called an artery, because of the direction of the flow of blood. But these vessels are blue because it's oxygen-poor blood. All right, the pulmonary arteries lead to pulmonary capillaries, where we have the exchange of gases, and then the pulmonary capillaries lead to pulmonary veins, and then the pulmonary vein goes back to the heart, which is what makes it a vein, and it is red because now it has picked up the oxygen, so it's oxygen-rich blood. Returns it back to the left atrium. All right, and this picture shows you what the alveolus looks like. And there are actually three types of cells that we find in the alveolus, and you have to know the difference between the three types. We have the alveolar type 1 cell. The alveolar type 1 cell is a simple squamous cell, and this is the cell where we have the exchange of gases. It's part of the respiratory membrane. The respiratory membrane is the membrane gases must cross through in order to get into the circulation or to leave the circulation and get into the alveolus. All right, so that's type 1. Then we have the type 2 alveolar cell, which are simple cuboidal cells. And these cells secrete surfactant. Now, surfactant is a lubricant, it's like a detergent, and it lines the inside of the alveolus and it prevents the alveoli from sticking to each other and it helps keep them inflated. If we didn't have the surfactant, whenever we would breathe air out, then the sides of the alveolus could stick to each other and it'd be harder to take a breath in. Whenever you take your very first breath in after birth, it has to be a really big breath so that we can fully inflate the lungs and then also inflate the alveoli. The third type of cell found in the alveolus is the alveolar macrophages, and they're going to help digest any type of pathogen that has been inhaled into the lungs. Now let's look at the right side of this picture. On the right side of this picture, it shows you the parts of the respiratory membrane. And there are three parts. First, we have the wall of the alveolus of the type 1 alveolar cell. So we have the simple squamous cell right here. Then there's a basement membrane in the middle. And then we have the endothelium of the pulmonary capillary. So those are the parts of the respiratory membrane, the endothelium of the pulmonary capillary, a basement membrane, and then we also have the alveolar cell, the type 1 alveolar cell. We have oxygen that's going to cross from the alveolus into the pulmonary circulation. Then we have carbon dioxide that's going to leave the pulmonary circulation and go into the alveolus. As we go through the bronchial tree and start with the trachea, which leads to the primary bronchus, if we're going to look at the tissues and see how they compare, we start with the tissues on the outside. There is a ring of cartilage, actually it's called an incomplete ring of cartilage, around the trachea. It helps keep the trachea open so that it doesn't collapse and close so we can breathe in and breathe out. This is hyaline cartilage. So as we go through the primary bronchus, the secondary bronchus, the tertiary bronchus, we still find the hyaline cartilage. But then when we get to the bronchial level, instead of having cartilage on the outside of it, there is a full layer of smooth muscle. This smooth muscle around the bronchioles will cause bronchial constriction, or they will relax to create bronchial dilation. So if the smooth muscle around the bronchioles are contracted, creates bronchial constriction, and it restricts the air going towards the alveolus, so it decreases airflow. If the smooth muscle around the bronchioles are relaxed, it causes bronchodilation. So now they have opened up and we allow more air to go into and out of the alveolus. All right, let's focus on this picture for a little bit. This is showing the mucociliary escalator. What happens is that the lining of the trachea and some of the bronchioles are lined with pseudostratified ciliated columnar epithelium, which is also known as PCCE, pseudostratified ciliated columnar epithelium. Anytime we have a columnar epithelium, we also have these cells right here, which are goblet cells. And goblet cells do one thing. They take mucin and they create mucus. So it creates a mucus layer. That's what the goblet cells do. Now there are channels located in the cell. We're going to look at it in the next picture, which are called CFTR channels, which are cystic fibrosis receptors. And what they'll do is they will pump chloride or chlorine into the lumen, which is the external environment, and wherever chlorine goes, sodium and water will follow in between the cells, and it creates a saline layer. This saline will help separate the mucus from the cilia. Now the cilia has one purpose. The cilia moves something across the surface of the cell. So the cilia is located in the pseudostratified columnar epithelium, and then we also have simple columnar that is ciliated that lines the uterine tube or lines part of the alimentary canal. Now the saline layer is really important. If we didn't have the saline layer, then the mucus would get stuck in the cilia and the cilia wouldn't be able to move. If the cilia is not able to move, then anything that we breathe in will just get stuck and cause infections. Let's look at the next slide for a second. This is showing you the CFTR channel. CFTR channel is in the apical surface of the cell, which means it faces the external environment, it faces the lumen. Chloride leaves through the CFTR channel, and then sodium and water will follow, creating a saline layer. Plus, there's also going to be some bicarbonate that's going to go to the mucus layer. That's why mucus is also alkaline, and it is a buffer. All right, if something happened with the CFTR channel and it closed off, this is what happens during cystic fibrosis. The chloride channel does not work in the apical surface, so it's unable to create the saline layer to separate the mucus from the cilia, and the cilia can't move, which is why those individuals that have cystic fibrosis are more prone to respiratory infections. There are two gas laws that you have to know. There is Dalton's gas law, and then we have Boyle's gas law. We'll get to Boyle's in a couple of slides. Dalton's law says that the total pressure of gases equal the sum of the partial pressures of a gas. In other words, if we take a container and fill it with a number of gases, if you add up the pressure of each individual gas, then it adds up to the total pressure of the gas. For example, normal atmospheric pressure is 716 millimeters of mercury. If oxygen is only 16% of the 760, then you take 16% of 716, that tells you the pressure of oxygen in the atmosphere. Boyle's law states that there is an inverse relationship between pressure and volume of a container. What it's telling you is that if you increase the volume of a container, then you will decrease the pressure. Or if you decrease the volume of a container, then you increase the pressure. In this picture over here on the right hand side, it shows you what happens when you decrease the pressure between in a container. If you take a plunger and you push the plunger down to decrease the volume, what does it do to the molecules of gas inside the container? Now, instead of being able to move around in this amount of space, they're only allowed to move around in this amount of space, which will increase the pressure. So, decreasing the volume of a container increases the pressure inside of the container. If you go backwards, change this arrow, going from this plunger size and moving it up. When you increase the volume of a container, then you decrease the pressure inside of the container. We're going to apply this Boyle's law when we look at inhaling and exhaling using the diaphragm and the other muscles of the thoracic cavity. In a couple of slides, we're going to look at the effects or how to read a pulmonary function test. And there are certain definitions you have to know first. These definitions are on this slide, which I'm just going to highlight, and then we'll go to the picture because I'm a visual person. When we look at lung volumes, we have tidal volume, inspiratory reserve volume, expiratory reserve volume, and then we also have residual volume. The bottom line is that the tidal volume is going to be how much air you breathe in and breathe out in a simple breathe in, breathe out. If you're able to breathe in as much air as possible after a simple breathe in, that would be the inspiratory reserve. And then if you were to measure how much you breathe out, how much you can force air out of your lungs after normal breath out, that would be the expiratory reserve volume. And then no matter how much air you breathe out of your lungs, there's always still some air in your lungs, and that would be the residual volume. Now, if you add some of these together, they create lung capacities. Like with inspiratory reserve capacities, when you add add the tidal volume plus the inspiratory reserve volume. And then we have the functional residual capacity, which is whenever you take the tidal volume and add it to the expiratory reserve volume. And then if you were to take the tidal volume plus inspiratory reserve plus expiratory reserve, that would give you the vital capacity. And then if you take the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume plus the residual volume, then that gives you your total lung capacity. All right, and this is what we're going to look at on this graph. This line here that goes up and down, this is showing you tidal volume, breathing in and breathing out. So when you breathe in, that's how much air you breathe in, normal breath in, normal breath out. Normal breath in, normal breath out, around 500 milliliters. We don't have to worry about the amounts. Now, after a simple breathe in, a breath in, and then you take in as much air as possible, take a deep breath in, that's the inspiratory reserve volume. So tidal volume, simple breathe in, and then you force as much air into your lungs as possible. That's the inspiratory reserve volume. All right, then if you take a normal breath out and then force as much air out of your lungs as possible, that would be the expiratory reserve volume. And then, like I said earlier, no matter how much you try to force the air out of your lungs, there's still a little bit left in your lungs, and that's the residual volume. Now if we look at the different capacities, if we take the amount that we breathe in, the tidal volume plus the inspiratory reserve volume, then that gives us the inspiratory capacity. That's how much air we breathe in during a normal breath and how much air we force into our lungs. Then if we take and add the how much air we breathe out plus how much air in the residual volume, it gives us the functional residual capacity. So the expiratory reserve volume and the residual volume, add those together, that gives us the functional residual capacity. And then if we take the air that we breathe in and breathe out and the inspiratory reserve and the expiratory reserve, that gives us the vital capacity. And then if we take how much air we breathe in plus how much air we breathe in and out during normal breath plus the residual volume, then that gives us the total lung capacity. The TLC stands for total lung capacity. In this picture, it actually applies Boyle's law to our thoracic cavity in our lungs. If we consider the thoracic cavity the container, if we remember Boyle's law, it says as we increase the volume, we decrease the pressure. So if we apply that to the thoracic cavity, if we increase the volume of the thoracic cavity, then we decrease the pressure. And it creates that pressure gradient we need in order for air to enter or exit the lungs. So the diaphragm normally, when it is relaxed, it goes up and forms a dome into the thoracic cavity. Then whenever the diaphragm contracts, like we show in this picture, it lowers down into the abdomen, which will increase the volume of the thoracic cavity. And when you increase the volume of the thoracic cavity, it decreases the pressure, and so then air follows the pressure gradient and goes into the lungs. The opposite of that will be what happens whenever the diaphragm relaxes. When the diaphragm relaxes, it normally goes back into its normal position, which will decrease the volume inside the thoracic cavity, which will increase the pressure and then force air out. If I were you, I would recommend writing this down and memorizing it several times. Increasing the volume of the thoracic cavity will lower the pressure and allow air to enter into the lungs. And then when you decrease the volume of the thoracic cavity, it increases the pressure, which then forces air out. So then we have to think, well, what will increase the volume of our thoracic cavity? Contracting the diaphragm. What will decrease the volume of the thoracic cavity? Relaxing the diaphragm. All right, let's look at this for a second. Flow, and when we're talking about flow, we're talking about flow of air. It is directly related to the change in pressure, which is actually the pressure gradient over resistance. So the pressure gradient is directly related to flow. So if we increase the pressure gradient, it increases the flow of air. So the higher the pressure gradient, the faster the flow. Now let's look at resistance. Resistance is inversely or indirectly related to the flow. So if resistance increased, flow decreases. And how do we increase resistance when it comes to the airways? It is constricting the bronchioles, known as bronchial constriction. Now let's talk about breathing in and breathing out. Breathing in is active because you have to use a muscle in order to inhale, and that muscle is going to be the diaphragm plus the external intercostals. Whenever those muscles contract, they increase the volume of the thoracic cavity, which decreases the pressure and allows air in. Whenever we are breathing out, though, exhale is a passive mechanism because the muscles are relaxing. There are no muscles for regular exhale or regular expiration. It is just a natural process because the muscles are relaxing. And due to the elastic content of the lungs, whenever they contract and then after they expand and then they go back to their normal size, then it forces air out. When we look at this picture, we're looking at three different measurements. First, if we look at this bottom graph, that is the volume of air that's moving through the bronchial tree. Then if you look at the middle graph, we're looking at the pressure inside of the thoracic cavity. They're calling it the intrapleural pressure. And then at the very top, we're looking at the alveolar pressure, the pressure inside of the alveolus. We'll start at the bottom and work our way to the top. Looking at the volume of air that's moving, this upward swing represents air moving into the lungs. What's happening to the thoracic cavity? Well, the diaphragm is contracting. And as the diaphragm contracts, it increases the volume of the thoracic cavity, which decreases the pressure. So, as the diaphragm contracts, it lowers the pressure inside the thoracic cavity and allows air to move in. And then when we go down, that means we're now exhaling. That means the diaphragm is relaxing. And it is increasing the pressure inside the thoracic cavity because it is decreasing the volume. And then we do this whole cycle again. The diaphragm starts contracting again. When the diaphragm contracts, it is increasing the volume of the thoracic cavity, which is decreasing the pressure, allowing air in. And then as the diaphragm relaxes, it is going to be decreasing the volume of the thoracic cavity and increasing the pressure. All right, so if we look at the middle graph and compare it to the bottom graph, this is showing the pressure. So as the diaphragm contracts, when you're breathing in, increases the volume and decreases the pressure, which is what this is showing. Pressure is decreasing inside the thoracic cavity. And then as we breathe out, the diaphragm is relaxing, which is going to be decreasing the volume of the thoracic cavity and increasing the pressure, which is what they're showing with this upward swing. Then inhale, we're decreasing the pressure inside the thoracic cavity, allow air in. And then exhale, increasing the pressure inside the thoracic cavity and allowing air to exit. Now let's look what's happening in the alveolus, because it's a little funky looking. As air enters into the lungs, as we breathe in, halfway through inspiration, pressure goes down, but now pressure starts going up. So halfway through the inhale, the pressure inside the alveolus goes up. And this is because there's air entering into the alveolus. This is the end game of the oxygen gas. And then we exhale. As we exhale, first pressure starts to increase inside the alveolus, and then mid-exhale, it starts to go down. Pressure is going down because gas is leaving the alveolus. And we do the same thing again. As we breathe in, as we first start to breathe in, pressure is going down inside the alveolus. And then as it fills with air, it starts to increase again. And then as we breathe out, the first part of exhale, pressure goes up inside the alveolus, and then it starts leaking air out into the airway, so then the pressure goes back down. In the lungs, there are two tissue properties that we look at, the elastance and the compliance. When it comes to compliance of tissues, we're talking about the ability to stretch. The lungs have a certain compliance to it and allows it to stretch. So as we inhale, the lungs have to stretch in order for allow air to enter into the lungs. Elastance is the opposite of compliance, is that it allows the lungs to return back to its normal size after inhale. So we have compliance and we have elastance. Anything that interferes with compliance and the ability to stretch will limit how much air enters into the lungs. And then anything that interferes with the elastance, it interferes with the lung's ability to let air out in order to go back to its original conformation or shape. As a review, surfactant is secreted by the type 2 alveolar cells. They're cuboidal cells. Surfactants are like a detergent and a lubricant, and it prevents the alveoli walls from sticking to each other. It helps keep them inflated so that as you breathe in and breathe out, the alveoli won't stick. Okay, do you remember this formula right here? Resistance is proportional to length times viscosity over radius to the fourth. That is good old Puiseuil's law, and we looked at this in chapter 14. We looked at it as well in chapter 15. Puiseuil's law is all about resistance. So resistance is directly related to length. As length of vessels increases, so does resistance. Viscosity. As the thickness of the fluid increases, so does resistance. And remember, resistance opposes flow. So anything that increases resistance decreases the flow, whether it's fluid or if it's an air. And then the radius. The radius to the fourth power is indirectly related or inversely related to resistance. So as radius increases, resistance decreases, and that will increase the flow. So how do we increase the radius when it comes to the bronchial tree, when it comes to the respiratory system? So we have bronchoconstriction. This is at the bronchial level. Bronchoconstriction is whenever the smooth muscle around the bronchiole constricts. Bronchoconstriction increases resistance, which then decreases the airflow. The parasympathetic nervous system creates or causes bronchoconstriction. Bronchodilation is whenever the smooth muscle relaxes. As the smooth muscle relaxes, the bronchioles will dilate, which will decrease resistance. So whenever we decrease resistance, it increases the flow. The sympathetic nervous system is responsible for bronchodilation because it allows more air to enter and exit the lungs so we get more oxygen into our circulation. Let's look at some definitions on this slide. First, let's look at anatomical dead space. The air that's moving into and out of the airways. If there's no gas exchange occurring, it's called a dead space. So we have anatomical dead space in the pharynx, in the larynx, in the trachea, the primary bronchus, secondary bronchus, tertiary bronchus, alveolar duct, the bronchioles. There is no gas exchange occurring in those areas, so that's called the anatomical dead space, which has a certain amount of volume. And then we have the total pulmonary ventilation. Total pulmonary ventilation is the volume of air moved into and out of the lungs per minute. And you figure out the total pulmonary ventilation by taking the ventilation rate, which is how much you breathe in, breathe out per minute, and you multiply it by the tidal volume, how much air you breathe in and breathe out. Now, this is more of a lab thing. It's not so much of a lecture thing, so I'm bringing it up now so that when you do the case study on breathing and the respiratory system on asthma, then you know the difference between total pulmonary ventilation. And then we have the next one, which is alveolar ventilation. Alveolar ventilation is how much air enters and exits the alveolus. Total pulmonary ventilation is just how much air is moving into and out of the lungs per minute. Alveolar ventilation is a little more accurate because it takes away the anatomical dead space. So we don't take that into consideration. So in order to figure the alveolar ventilation, you take the ventilation rate and you multiply it by, you take the tidal volume and you subtract the dead space. Let's follow this chart. If we start at the very end of inspiration, when we fully bring in air in as we breathe in, we have a total of 2,700 milliliters of air that enters through the airways. 150 milliliters of that is the anatomical dead space. And then when we exhale, as we exhale, the very first air that exits our lungs is going to be the 150 milliliters of the dead air space. And then we have also air coming out that adds up to around 350 milliliters of air of carbon dioxide leaving the lungs. That's expiration. So then at the very end of expiration, we now have 2,200 milliliters of air in the lungs, and 150 of it is in the dead air space, and it's stale air. It's oxygen poor air. So then we start breathing in. The 150 milliliters of air that we first breathe in is from the dead air space, so it's stale air. And then the rest of the air that we breathe in, the 350 milliliters, is oxygen-rich air. And then at the very end of inspiration of inhaling, we have 2,700 milliliters of air total inside of the lungs, and 150 of that is in the dead air space and is also oxygen-rich air. The last thing I'm going to talk about in this chapter are a couple definitions. We have hyperventilation and we have hypoventilation. With hyperventilation, you're breathing in and breathing off a lot of carbon dioxide and oxygen. You breathe in a lot of oxygen, breathe in a lot of carbon dioxide. So when you hyperventilate and you breathe out a whole lot of carbon dioxide, it will raise your pH and make you more alkaline, which is why one of the compensations for hyperventilation is to breathe into a paper bag so that you can breathe some of that carbon dioxide back in so your pH will return to normal. Hypoventilation means that you're not breathing enough, so your oxygen levels will drop and your carbon dioxide levels will rise. As your carbon dioxide levels rise, then that will lower your pH and make you more acidic. If you have any further questions about this chapter, feel free to email me at any time.